Hi everyone! Welcome to our research proposal presentation on characterizing interpersonal difficult situations and mode use in telehealth occupational therapy sessions by Kelly Reynolds and Cicely Tom. The general aim of this study is to look at how occupational therapists can build rapport through the use of telehealth. So let's take a look at all the things we already know. So we know a lot. To begin, let's take a look at telehealth and what we know about this type of health-related service. The early uses of telehealth were with acute conditions, but now is expanded to be used for a variety of conditions. The use of telehealth is expected to spread within the decade due to the overwhelming positive results from the service, and I'd like to believe our current situation has definitely sped up this expectation. There's a lot of research behind telehealth, and studies show that interventions are able to be successfully implemented through the screen, and that those that receive telehealth services are typically highly satisfied. Along with it being successful and convenient, telehealth is also financially helpful. Research shows that using telehealth reduces the cost of service for both the receivers and the providers. Additionally, telehealth is a great option for those that live in rural or underserved areas, being that studies show that majority of those in these areas both use and have access to the internet. A common style of intervention used with telehealth is called coaching, which is a super collaborative and problem-solving approach to therapy. Occupational therapists tend to use a more specific type of coaching, called occupational performance coaching, which focuses on asking specific questions in order to allow clients to be able to problem solve through situations with hopes to increase their participation in occupations. In order for coaching to work, therapists need to have built rapport with those being coached, which brings us to the next bullet point, the intentional relationship model, or the IRM. The IRM is a model that aids therapists in enhancing their interpersonal skills, which in turn allows for greater rapport building with their clients. Studies show that occupational therapists actually rank therapeutic use of self as the most important skill for their profession, as well as rank there being inadequate knowledge about this important skill in their field. Dr. Renee Taylor explains that the IRM is focused on 4 specific components of the client-therapist relationship, being the client's interpersonal characteristics, the client's response to interpersonal events, the therapist's use of interpersonal modes, and the occupational outcome. Focusing on these 4 components and better understanding them can allow for positive outcomes of therapy and great rapport building. Zoning in on the component of therapist use of interpersonal modes, the IRM labels 6 of these. There is advocating, collaborating, problem solving, instructing, encouraging, and empathizing. Using the appropriate modes throughout a session helps build rapport and use a therapeutic use of self, which Dr. Renee Taylor defines as the application of empathy and intentionality in an interpersonal relationship. The IRM has an evaluation called the Clinical Assessment of Modes, or the CAM. There are 4 minorly different CAMs, differing based on the point of view you desire, but they all look at the mode usage of a session. There are many studies on the CAM, and it is found to be both reliable and valid in a variety of different settings. So overall, we know that telehealth is a great and successful service tool that is getting used more and more nowadays. In order for telehealth sessions to be as successful as possible, it is necessary to develop rapport with your client. Therapeutic use of self is a great way to create this rapport, and the IRM is a tool that allows therapists to intentionally use specific types of communication in order to implement this use of self. All that being said, therapeutic use of self is one of the highest ranked skills amongst occupational therapists, and there's not enough information on this topic. So, our research question, or what we want to know, is how do occupational therapists use the IRM and its associated modes to develop therapeutic rapport in a telehealth intervention? Now moving on to the methods. Data in this study will be gathered from recordings of previous telehealth sessions conducted with parents of children with ASD ages 2 through 7 years old. Inclusion criteria for these videos will be those of participants of the telehealth sessions that completed their whole intervention plan, while exclusion criteria of these videos will be those with technical difficulties such as lost sound. We will be assessing 4 different occupational therapists within 30 total videos. We plan to use 3 different treatment session videos, one from the beginning, one from the middle, and one near the end of the intervention from 10 telehealth participants. We will not use the very first or very last session. Moving on to the measures, we will be using the CAM-O in this study. The CAM is an assessment of therapists' mode usage based off of the IRM that has shown acceptable reliability and validity in the rehabilitation and outpatient pediatric populations. The CAM-O is based on observation and has 30 questions that ask about the therapist's use of the 6 modes in the IRM and 6 questions on overall impressions. The CAM-O uses a Likert scale from 1 being never to 4 meaning frequently, and then 5 meaning not applicable. An example of a question that assesses the therapist's use of the encouraging mode in the IRM is, the therapist pointed out what the client was good at doing. For procedures, we will be trained by Dr. Jenny Popova, an IRM expert in the field, to rate mode use in telehealth sessions. We will reach inter-rater reliability on the CAM using videos not included in the study. Intraclass correlation coefficient will be used to assess achievement of inter-rater reliability. We plan to watch the telehealth videos and code them separately, although at the same time, and communicate after to then confirm the session's final score. For data analysis, we will use descriptive statistics to analyze the scores we have coded using the CAM. We will analyze these scores both within the subdomains and overall. Specifically, the descriptive statistics will be used to look at variability among therapists and change across time. We will look at change across time by analyzing the descriptive statistics at the beginning, middle, and end sessions. One difficulty we might face is achieving inter-rater reliability. If we are not able to get reliable with each other after the first time watching through the videos, we will have to go through the process again. Additionally, we are currently in different time zones. It will be important to pick a time that works for both of us to review the videos. Another potential difficulty is the amount of videos we will be coding. It is important for us to make sure we are completely focused while coding the videos to eliminate the need to go back and watch the videos again because of how many there are. Furthermore, to minimize potential bias while we are coding, we will also put together a tip sheet and will be discussing our expectations and reviewing rating guidelines before starting the process. Thanks so much for listening, everyone, and then here are our references.